The treatment options are excision and flap, laser, and episode. These are the conventional treatment. All my patients only, where I did excision and leave it open, which is the best option. Then the Z-plasty and the limber flap. Hemorrhoids. It's the most common anorectal condition. As you all know, about 50% of the population is affected in the whole lifetime, and about 5% is affected at any point of time. So it's the most common anorectal condition. And the pathophysiology includes venous causes, arterial causes, connective tissue, and the muscular. So there can be a single pathology or multiple with varying degrees of involvement. And the success of the treatment would lie in identifying the pathology and providing the correct treatment. The management includes dietary and lifestyle modification, medical management, where the only statistically proven molecule is the micronized purified flavonoid fraction (PFF). Then there are outpatient procedures like rubber band ligation, injection sclerotherapy, infrared coagulation. This can be done as outpatient with local anesthesia. And then there's the classic surgery, which is the Milligan-Morgan hemorrhoidectomy and the Longus staple hemorrhoidectomy. And the topic of our discussion today, laser. And laser is light amplification by the stimulated emission of radiation. And it has been there, laser has been there for a long time. And it has been used in medicine and surgery for a long time. But it's only recently that it is being used in proctology and varicose veins. The effect of laser depends on the wavelength. A particular wavelength is absorbed maximally in a particular body fluid or tissue. And the green line indicates the absorption of absorption of laser by hemoglobin, and the blue line indicates that of water. Earlier we used to use 980 wavelength, but now everybody is using only 1470 wavelength. And as you can see, carbon dioxide is absorbed more in water, and its wavelength is 10,600. So, the depending on the wavelength, the rate and amount of absorption to the tissues differ. The effect of laser in proctological conditions is by heat. The heat generated is the mechanism of our treatment. So when the heat is more than 40 degrees centigrade, there is enzyme injection, membrane disintegration, and edema. When the heat is between 45 to 60, there is tissue damage. When the heat is between 60, more than 60, there is coagulation, protein degeneration, and coagulation. And when it is more than 100, there is dehydration, carbonization, and vaporization. In proctology and varicose veins, our aim is to keep the temperature between 60 and 100 so that there is coagulation and protein degeneration, and this coagulum obscures the cavity or makes the two walls stick together. That is our purpose. Our purpose is not to create, dehydrate, and carbonize and char the tissue. It is not our purpose. Our purpose is to coagulate protein degeneration, and the walls should stick and the space is obliterated. That is our aim. This is tissue reaction and action. The first one is it is by carbon dioxide laser. And the second is our 1470 laser. As you can see, carbon dioxide laser cuts sharply with very minimal tissue reaction. So it is ideal for precise cutting. And 1470 laser cuts bluntly with wider tissue reaction. And as I told earlier, our aim is not to cut precisely. Our aim is to coagulate, create tissue reaction, and make the surfaces adhere and obliterate the space. So that is why carbon dioxide laser is ideal for very precise cutting like ophthalmological surgeries, and 1470 laser is ideal for proctological conditions and varicose veins. This is the corona of the laser fibers. There are two types of fibers, ideally actually three, but mainly two. One is the radial fiber, which radiates in a circular fashion. So most ideal to obliterate cylindrical pathology like fistula or varicose veins, and the other is a pointed, just like a point of fire or heated point, and that is for hemorrhoids and fissure. This is my own data for the last 3 years. I have worked in Kerala, that is a state in India, and Oman. The total number of cases is 219, and laser cases in star care. Today I did the 30th. And this is the division. Conventional includes all the conventional, including the what I showed. But I was more interested in minimal access, so no hemorrhoidectomy. There is no Milligan-Morgan hemorrhoidectomy in my list. But what you see conventional is either hemorrhoidal artery ligation with the rectocanal repair or stapler hemorrhoidopathy. So fissure in nano, lateral sphincterotomy done conventional method for 7 cases, laser done for 2 cases, and total 9 cases. Fissure in nano and hemorrhoids, where the main complaint is fissure, but the patient also has a hemorrhoid. So such cases, conventional I have done only one, that is hemorrhoidal artery ligation and the lateral sphincterotomy. And laser I have done 33, totaling 34. Hemorrhoids and fissure, where the complaint is hemorrhoids and the patient also has a fissure. 19 conventional, of which 16 were staplers and 26 lasers, totaling 45. And pure hemorrhoids alone, 22 staplers and 52 laser, totaling 74. And then there is recurrent hemorrhoids, where a previous procedure was done and it failed and recurred. Such 2 cases, both were dealt with laser. Then fistula in nano, where conventional means it's lift, and 11 cases of lift and 22 cases of laser, totaling 33 cases. Then there is recurrent fistula in nano, where already 1 or 2 procedures were done and all of them were dealt with laser. Then fistula in nano with fissure, where I did a lateral sphincterotomy also, it was done by laser only. And there is recurrent fistula in nano and fissure in nano, 1 case done with laser. Pylonidal sinus, I have done 3 cases in conventional and 7 cases with laser, totaling 10. All the 3 in Oman were shown to you. One was by excision, one I did Z-plasty, and the other I did limbar flap. And recurrent pylonidal sinus also 2 conventional and 1 laser, totaling 219 cases, of which 65 conventional and 154 laser cases. The results in hemorrhoids, 80% of the patients chose medical management rather than jump into surgical procedure. But in fistula and pylonidal sinus, it was the other way around, where 80% chose surgery, and even the 20% didn't do the surgery because of cost or other hospitalization, job factors, all those things, where they didn't want a hospitalization. The mean age was 45 years, and youngest was a 13-year-old girl with a pilonidal sinus, and oldest was 85-year-old with a hemorrhoid. The male-female ratio is 2:1, and the average hospital stay of laser patients is in hemorrhoid and fissure in ano, it was only 8 hours. In a pilonidal sinus, it was 12 hours, and in fistula, 3 days. This 3 days, I can actually send the patient the very same day or within 12 hours, but I keep the patient nil per oral and give intravenous fluids and antibiotics so that I can prevent infection. The post-laser return to normal routine. In hemorrhoids and fissure, it's 5 days. Pilonidal sinus 7 days, and fistula in ano around 14 days. The complications of laser is mainly not due to use but misuse or disuse. It is thermal injury to the mucosa and the internal sphincter, hematoma and clot formation. That's mainly seen in patients with very redundant mucosa due to the hemorrhoid mass. Then there is postoperative bleeding. That is mainly when there is a clot formation and the clot sloughs off. That too, grade 3 and 4 hemorrhoids. Then infection and perianal abscess. I had only one case of perianal abscess. The reason I don't know. Not immunocompromised, but one case of perianal abscess was there. Then there is pain and there is recurrence. Contraindications. There are no major contraindications for laser in proctology. Concomitant local malignancy is a relative contraindication. Then there can be anesthetic contraindications or anesthetic risks and general condition where any surgery is not preferred for that patient. But even in such conditions, laser would be the most ideal because it provides, it has the least trauma to the patient. I actually had 3 patients who had, one had a liver disease and 2 had malignancies, and they were terminal, but their main complaint was bleeding per rectum from the hemorrhoids, and they knew their fate, they knew their condition, but still wanted laser. And even though they died within 3 to 4 months, they were very happy regarding the result of the laser. So that is that's actually a good indication rather than a contraindication where the patient is old or debilitated. Then the least possible trauma is by laser, and we can provide good relief to the bleeding, prolapse, and all those things. So laser treatment of fissure in ano, hemorrhoids, fistula in ano, and pilonidal sinus has the advantage of lesser operating time, lesser skin trauma resulting in lesser pain, lesser hospitalization, and quicker return to work. Laser treatment has the options of general anesthesia, spinal anesthesia, or even local anesthesia with sedation as a method of anesthesia. So a minimal anesthesia can be used in selected cases. Laser treatment has comparable results with regards to relief of symptoms and recurrence when compared to conventional methods. The role of non-surgeons. Most cases of fissure in ano, hemorrhoids and fistula or pilonidal sinus may first approach a general practitioner, a physician, or even a gynecologist. Especially in Oman, female patients usually might approach a gynecologist for their condition. And conservative treatment can be tried in the case of hemorrhoids with MPFF, diet modification, sitz bath, and fissure in for up to 3 weeks. And maybe refer to a surgeon if conservative management fails or the illness recurs. So there is no need to refer the patient in the first instance itself. But if the medical treatment fails or it recurs, you can refer. But in the case of fistula and pilonidal sinus, it's always better to refer the patient to a surgeon at the first instance itself because they are surgical conditions and any relief is only very temporary. We can only control the infection with antibiotics. If medical management alone is not effective, laser is the most suitable first-line treatment method for most types of hemorrhoids, fistula, and pilonidal sinus. Laser has made the treatment much more quicker and easier for both the patient and the surgeon. Stapler and conventional methods of management still have a place in the treatment protocol in selected cases. Just like I said, if there is a lot of mucosal prolapse, then stapler would do much better than laser, and it would prevent collection of blood and clots and then further bleeding and pain. Video assistance, mainly in WAFT and EPSIT, that is WAFT for a fistula and EPSIT in the case of a pilonidal sinus, is an upcoming helpful tool for treating fistula and pilonidal sinus under vision in recurrent cases due to multiple side tracks. So we are planning to have a WAFT also very soon, so that we will have the complete armamentarium for the proctological conditions. As a picture is worth 1,000 words, I told you my oldest patient, grade 3 hemorrhoids. This is pre-op, pre-laser, and then is post-laser. I have not even removed the sheets. This is my oldest patient, grade 3 hemorrhoids. And this is the worst case of hemorrhoids that I have managed with laser. Grade 4, irreducible. The patient could not sit. He came standing. That is an immediate post-laser picture. And this is after 3 weeks. And this is our staff care team ready to help and serve. And as you all can see, I'm conspicuously absent from the picture because I took this photo after our first case of laser in our OT. So I'm behind the camera. So I'm there with the team. Thank you.
If somebody asks. Thank you, Dr. Habib. Wonderful presentation. And as you rightly said, it is not about using any particular modality. It's a very wise combination of various modalities that results in the best outcome. And believe me, laser has totally changed the attitude of the public towards the treatment of hemorrhoids. May I now invite Dr. Arthur Agustin to share his views.
Thank you, Dr. Sukumar. Good evening, all. As was just explained very clearly, the pathophysiology of hemorrhoids has many components, and therefore, the way the hemorrhoid presents to us, there is a spectrum of cases which we see. And because there is a spectrum of cases, we cannot make it a uniform treatment. And so correctly, Dr. Sukumar said that the treatment must be tailored to each individual patient. So then why do we have laser suddenly coming up? First of all, it is not sudden. Laser is not new. It has a variety of applications, and it is not even in proctology, it is not new. What we have come to realize over time now is that Just like the pathophysiology has a spectrum of causes, the treatment also must have a spectrum. And many of the treatments for hemorrhoids, as you can see, the treatment is evolving. And that is because we haven't found an ideal treatment for hemorrhoids as yet. Every type of treatment every type of non-surgical treatment involves some sort of transfer of energy to the hemorrhoid to obliterate the hemorrhoid. There can be no more accurate or precise delivery of energy than that is produced by the laser. And that is why laser will surely be the way forward for maybe grade 2, grade 3 hemorrhoids. Beyond that, we'll have to look at other options. It is not that as soon as a patient comes with hemorrhoid, he is targeted for laser. He has to be assessed. We have to see which of all the treatments existing will give him the maximum benefit. We may have to combine laser with something else, maybe a hemorrhoid artery ligation, or if he's got a prolapse, then maybe we should opt for a stapler instead. Mucosal prolapse is very common with the larger degrees of hemorrhoids. And simply doing laser will not help this patient because the mucosal prolapse will continue and he will still feel some symptoms. So we have to tailor make the treatment. In all this, we must not forget that hemorrhoids and even fissure for that matter, these are lifestyle diseases and therefore they are going to increase with our diet and our lifestyle. These diseases are going to increase. And irrespective of what treatment we offer, which modality we offer, we must not forget the lifestyle management which the patient requires. Thank you very much.
Thank you, Dr. The outlook of treatment, the whole concept of treating proctological issues are now being reduced to a simple daycare procedure where the patient can be admitted in the morning, get operated the same day, and going back to home a few hours after recovery from anesthesia. And even going back to normal work life next day. To tell you the truth, one of our early patients whom we operated here, he was coming all the way from Sohar. You won't believe, 2 hours after recovery from anesthesia, he wanted to drive his car alone without an accompanying person back to Sohar. I did it. Reaching home, he called me back. I'm absolutely all right. I'm going to work from tomorrow. So that is the change which has happened in proctology. In no other field of surgery, the concept of disease, the pathophysiology, the anatomical concept, etc., have changed as it has changed recently in hemorrhoids. The concept has totally changed. For example, when Dr. Alfred mentioned hemorrhoid artery ligation, when it is very wisely combined with other modalities, on table we can experience that result. And of course, laser is the other magic tool that has made the treatment totally different now. And of course, this is not possible without supporting evolutions in anesthesiology as well. So may I invite Dr. Sadi Kodakar to throw his views on the subject.
Assalamualaikum. Sorry guys, you'll have to wait for 2 or 3 minutes.
No problem.
I will not take too much.
No problem.
Let me just stand here with 2 roles, being an anesthesiologist, a consultant anesthesiologist. I also practice, even though not as often as I would like these days. Anesthesia from laser or proctology point of view, whether it's laser or conventional, we will have certainly the 2 choices, which are either spinal anesthesia or general anesthesia. With laser, we do now have an option, or if you want to do a local and sedation. Now, I know that there are some surgeons who do or attempt to do laser with, especially for hemorrhoid, with very mild sedation or no sedation, depending on, let's say, if you're in a facility where you don't have the anesthesiology and the monitoring setup. But in with my experience, I think it will be limited. So from I think all of them use anesthesiology service along with even for laser. For laser with sedation and local, then it will be very difficult for deep sedation in a very steep lithotomy with head down position. So what we normally do, I do not here, but in elsewhere where I have worked with laser surgeons, we've been doing on the lateral position. But that's a bit of reorientation for surgeons to do a hemorrhoid or any proctology work. I got exposed to proctology originally from Star Care in Calicut itself. I've been doing anesthesia for nearly 30 plus years, so we all have seen all kinds of surgical evolution happening in front of our eyes. I'm usually at the head end, not on the other side, but still we know what is happening on the other side. So it's, as Dr. Habib said, laser has been, and Dr. Alfred said, laser has been around for a long time in various areas. I mean, in cosmetic and in prostate, and and we actually have urology laser with us in Star Care Muscat itself, and ophthalmology is very, very popular. But in the proctology field, it's been pretty recent. We all have been raised with banding and a lot of other conventional methods, as Alfred used to say. When there are a lot of treatment options, that means that no option is really a good option because everybody is confused and everybody wants to try out, and it depends on a little bit of your experience and all. But in the last 2-3 years, those I have seen now in front of my eyes, and especially in Star Care in Kerala, where our surgical team has started laser, I have seen a good, I would say a massive change from conventional. Very few patients now offer conventional. It's all become laser. Once doctors are trained and surgeons are trained and feeling very comfortable. Over there, actually, I have to say we have 2 laser machines, and we also do a lot of laser varicose veins. So my exposure is, this is what my exposure is. Then I was working in Dubai as an anesthesiologist, and I started seeing a lot of laser. Again, we were doing a lot on the lateral position with me being an anesthesiologist, we were giving sedation. Well, 6 months ago, I came to, even though I've been setting up Star Care in wherever it is, I never had an opportunity to be there and work there except in the last 6 months in Barca. And then we were just talking about what else can we do, what else can, new things. And Sukumaran was there. So we just, one discussion led to another, and we started talking about laser, and we realized that there are no, full-fledged. I know that some surgeons have attempted using laser. Some people do occasionally laser in Oman. In fact, in Star Care Muscat, we had done laser with our Richard Wolf machine, I think about 3 or 4 years ago. But we could see that when the operators are not full-fledged with it, and then they don't follow it through, and they never had the full-fledged training, they're not able to get a good result, good feel of it. So it didn't really fly. So once we started talking about, can we have somebody who is fully trained, who's done a lot of it, so that, because we want to fully establish a larger program rather than just giving a one attempt and then go at it. And then we were talking about that, we realized that there are 2 surgeons in this country who have done more than 100 lasers. So, and one is Dr. Habib. So we immediately got hold of him, and that's how the whole laser proctology program started. We named it branded it as a laser proctology, just to get attention, as well as that is the core agenda of laser proctology or proctology service in the modern time. But it's not just laser. It's, as they were saying, they do stapler, they do look at the other methodology. And actually, in about 2 months, we will be starting the video-assisted anal fistula treatment, and we'll be starting the endoscopic pyranidal sinus treatment as well, the EPSIT and the WAFT. we're just waiting for the gadgets to arrive and people are fully trained on it. We are also just about to start the laser varicose vein treatment. That's a different stream. Yeah, it has been a fantastic last one. So we only started doing just 1 month ago, just precisely 30, yeah, exactly 1 month ago actually. Dr. Nasser Shugeli from Rosak kindly came and blessed us and opened, and it's been a phenomenal success, I have to say. We are really overwhelmed, as Sumaran was saying, that we're getting patients from Ypres, Sohar, Sur, Muscat, all over, and there is certainly a need, and we are getting a lot of inquiries. So we thought that's important that we are obviously now start doing knowledge share. That will be initially more of an awareness, and then later more of a training for other surgeons and doctors. So that's why we specifically call it a Proctology Institute, because the vision is to not just provide a service, to be a training center. So we can start doing workshops and things like that. For the time being, we are doing the training or the awareness classes for the public. We've just started every Saturday a free awareness classes every Saturday available in Starcare Barka for public. Just as a video session with a question and answer session for doctors. People are not fully aware of it, they're just beginning to ask about it, and hopefully it will become a success of people, whoever, and it's not free, so nobody don't have to pay anything, they can simply understand more about it. And we are also just not starting in Barka, which is going to be starting, we have just started in Starcare Mabela, soon we'll be starting in about 2 weeks, we'll be starting in Starcare Barshar, and eventually Dr. Alfred and team will, Dr. Alfred is the head of surgery, consultant surgeon in Starcare Muscat, so he'll be starting up setting up the program over there as well. We also have a fantastic website. It's a little bit in the early stage, there's a lot more work to be done. That's called www.muscatlaserproctology.com. Essentially, we have plenty of websites, Starcare and other plenty of websites for ourselves. But we think that this subject is so much of importance that need a lot of unique attention. So we are actually uploading a lot of scientific articles, a lot of articles for public, for the information leaflets. So question answer sessions, videos, presentations. We are just, it's building up. It's not full-fledged yet, but please feel free to log in and have a look at it and do send some comments and give us feedback. So it will be inspirational for us to take it to the next level. Thank you very much for listening, and thank you for coming.
Thank you very much for the time. I don't want to prolong from one side. It's not even that monologue. Let us proceed on to the most exciting part of the session, like with the interactive session. So I'm sure because many of us are surgeons, there will be a lot of questions, I hope. So can we please pass on the mic?
After this laser therapy, I know our anesthesia, there is chances of anal incontinence. Any percentage you did not mention in complication. If there is any chances are 0% chance.
It's how you do the surgery. As we all know, incontinence is from when the external sphincter is affected. So my technique is always, there are two techniques. One in which you go through the mucosal side and cut laterally along the internal sphincter. But I never do that. The argument for this is that if you cut along in the direction of the mucosa, you will injure the mucosa and it will cause bleeding and it will cause pain. So what I do is that I don't follow the other procedure where you cut laterally. Then you can cut more into the external sphincter. I cut medially, but I do protect the mucosa by injecting saline and raising the mucosa so that I don't injure the mucosa. So, and I can actually, with a curved probe, I can actually hook the internal sphincter and cut it, and it will give the feeling of give way when you have cut it completely, and you can and you can feel the defect also, and it won't, as mucosa is elevated by with lignocaine and normal saline, it won't injure the mucosa also. So don't cut in the direction of don't cut laterally, you cut medially so that you don't injure the external sphincter. Go through the intersphincteric space, cut medially. That is my, and I never had any incontinence, even to flatus.
Thank you, Dr. Habib, for the nice presentation and nice authority as well. I've been lucky to attend and have the privilege to attend Dr. Habib few of his cases. Actually, laser, I think is going to be a revolution in the proctology because our understanding has advanced a lot for hemorrhoids. You mentioned about the arterial flow, you mentioned about the arteriovenous connection of the submucous venous plexus. When we were in medical student, our understanding that hemorrhoids are veins, this is no longer the situation today. We are now pretty sure that the arterial component for hemorrhoid as a factor. And the hemorrhoid laser treatment actually addresses almost all of the theories now are standard or accepted as a standard for explaining why some people develop hemorrhoids. Studies showed the arterial flow, for example, is 3 times the normal flow for patients with hemorrhoids. The arterial size of the diameter of the vessels also are wider, and later act by energy, which is actually the heat. And any mode of heat can work the same, but the advantage of laser being a measured heat, a gauged heat, the fiber 1470 we use here in Parka for treating hemorrhoids give an energy which creates coagulation and destruction of the vesicle of the hemorrhoid at 22 millimeters. This at the same time, because we are surgeons, we were trained not to cut, not to do any intervention without seeing. In case of hemorrhoids, by laser, you go by the conical or the bare fiber, the base of the vesicle, and you apply this energy blindly. This is the only thing that make me as a surgeon a little skeptical about this, because the site of administering the energy, this is the issue. At this point, whether if the heat extends beyond the needed point, then it can create a problem for me. That's what exactly.
Yes, that point is well taken, but any procedure has a learning curve. So once you negotiate the learning curve with innovation from inside, that gives the best result, I think. What is the
I agree with Dr. Abugazil. As you go higher, it is more bright. You don't get the artery. But earlier, I used to deal with the artery, like what he said. I used to deal with the artery first through the anal canal, not from the side, through the anal canal. And at that plane, we cross over the anal mucosa to the rectal mucosa. So even if you damage the rectal mucosa a little bit, it is not going to be painful. But that was earlier. So that I used to call hemorrhoidal artery ablation with laser. But now I don't do that. I do hemorrhoidal artery ligation. I ligate the hemorrhoidal arteries first with a figure of 8 suture. That gives me 2 advantages. One is when I go through into the venous plexus, This ligature will stop me from going up further. So it will limit my proximal laser migration, and it will limit my and it will ablate the or it will ligate it will obscure the hemorrhoidal artery. What he said is very correct, because even if you notice the bleeding from a hemorrhoid, it is bright red. It is arterial blood. It has been proven biochemically that it is arterial blood, not venous blood. So, ablation of the hemorrhoidal arteries. Uh, I have ligated up to 6 arteries in a lady. I had to put 6 ligatures in that small space. I could identify 6 vessels and 6 arteries I had to ligate. Usually 3 would suffice, but 4 and up to 6 I have ligated. And sometimes I don't get the artery because I use only my finger to palpate for the artery. If you have DG help, when Doppler guided hemorrhoidal artery ligation, you get more accurate arterial ligation. And arterial ligation is most important in preventing recurrence. For at that time, when you deal with the venous plexus, you will get a relief of all the symptoms, pain, bleeding, everything will stop, but it will recur if you don't deal with the arteries.
I'm Dr. Sadia Sajid from Wadi Marvel Health Center. One question is this laser hemorrhoidectomy is safe in pregnancy?
It is very safe. It's not actually laser hemorrhoidectomy, it's laser hemorrhoidopexy. As if you remember, I always said our aim is to coagulate and obliterate the two surfaces, obliterate the space, and glue the two surfaces together. So the right nomenclature would be hemorrhoidopexy. It is safe. Only problem is with the anesthesia. So, if there are no anesthetic contraindications, we can do laser in pregnant women.
In any trimester?
No, that depends on the anesthesia. If you can give anesthesia, we can do laser. Because as Dr. Abu Qasim has said, it is not there is no radiation. There is no, so it doesn't affect. It doesn't matter which trimester, and it is only heat that is being applied, and the heat spread is only 2 millimeters around the fiber. So there is no contraindication for pregnancy unless there is a anesthetic contraindication.
He's talking too much about anesthesia, so I thought I might as well step in. Yes, the laser itself is a very local energy delivery, so that doesn't cause anything to pregnancy at all. I think there are two aspects maybe to quickly to discuss. I'm not a surgeon and I shouldn't be on my area of expertise still. As we all know, in pregnancy, what you really need to think about is that really needing an intervention or not, because most of the hemorrhoid after pregnancy will resolve by itself. So maybe an intervention is not needed, but if you need an intervention, certainly it is possible. Anesthesia and especially the post-operative little bit of pain medicine that you may need, let's say, and simple non-steroidals, you don't normally give it to pregnant people. So let's say as a standard precaution, if you can avoid first trimester, you avoid first trimester. The second trimester, third trimester, it's not a problem at all, and it's a very much doable under pudendal anesthesia, spinal anesthesia, very low spinal anesthesia, without affecting the baby. But like everything, standard advice would be avoid procedure during pregnancy if you can. Yeah. Any other questions?
If there are no more questions, can I invite Mr. Abdul Ghani Santos to make his brief presentation? Thank you.
Good evening. Thanks to all doctors and especially thanks to Dr. Habib Mohammed for sharing wonderful presentations. I hope it will be very useful and very informative session for your day-to-day clinical practice. And I would like to thank all these experts, Dr. Sadiq sir, Dr. Sukumara and Dr. Alfred, the expert team, as well as the doctors. Myself, Abdul Ghani, I am associated with this Sandoz, which is a division